Welcome to this the September Wye Valley Board. Lou, could you turn on the recording for me, please? And we start off our board with a celebration of some of our Going the Extra Mile winners for Q1. And so first up are the team of the quarter, and that's our pathology team. And I'll just read out the nomination, and pleased that hopefully, I know some of them on the call, Kath, Andrea and Goran are with us. But following the unexpected APAX issues, which were a nightmare, that disrupted our operations from Friday, June the 21st until the 25th, every member of the pathology team demonstrated extraordinary commitment and resilience. Despite the severe challenges caused by this outage, staff across all disciplines worked tirelessly. Many team members extended their working hours significantly, and some even cancelled their annual leave to come in and help Wye Valley to continue to provide a safe and reliable service. The willingness of team members to change their weekend plans at the last minute, because this occurred over a Friday to a Tuesday, and provide mutual support was truly inspiring. Their dedication to patient care, the nominator wrote, ensured the blood sciences laboratories maintained a 24-hour service, delivering essential pathology results without the use of our central laboratory IT system. Their quick actions preserved samples, reduced the need for repeat collections, and prioritised processing those with the highest clinical urgency, which did not go unnoticed by clinicians. The pathology team's collective efforts ensured our services remained operational with minimum disruption to patients. So the dedication, resilience and unity displayed by the pathology team during this challenging time has been truly inspiring, the nominator wrote. Their ability to rise above adversity and work together as one cohesive unit is a testament to their professionalism and unwavering commitment to excellence. Pathology team, you are worthy winners of our Q1 Going the Extra Mile Team Award. Big round of applause to the pathology team. And colleagues who are on the call, can you go back to your colleagues and thank them for all of their efforts? But thank you very, very much. And then our employee of the quarter is Laura Moss. Give us a wave, Laura. So Laura is our urology patient stratified follow-up lead, PFSCU lead, and it's a remote monitoring program for cancer patients. The PFSCU program gives patients more agency within their healthcare in a safe and holistic way, with signposting and guidance if they should need to access extra support. PSFU benefits the trust, freeing up clinical time and thus easing waiting times and accessibility for patients who need the service. Laura has taken the lead on the implementation of the PSFU, liaising with a wide variety of stakeholders, admin teams, IT and patients to ensure the smooth implementation and delivery of this new service. She's coordinated the implementation of PSFU with 60 plus urology patients now established on the programme, saving over 40 hours of clinical time each year. As the project is ongoing, we do not have the final cost reduction timing savings yet, but it's a winner. So Laura, you've made enormous efforts to get this service up and running. You've definitely gone the extra mile on behalf of everyone at the Trust, and in particular the clinicians and the patients in the urology service. Big round of applause to Laura. You're a worthy individual winner of our Q1 Going the Extra Mile Award. Thank you. Now you're more than welcome to stay with us for the rest of the board team, but equally I will understand if you want to go and do other stuff. But lovely to see you all nonetheless, and like I said, thank you very much for your hard work. So we'll get going with the board, and first of all, apologies. We have apologies from Erica Herman. I don't think we've got any other apologies, so we'll move on to any new declarations of interest. Please raise a digital hand. Okay, can't see any hands raised. So the minutes of the meeting held on the 4th of July. If you weren't happy with the accuracy of those minutes, could you please raise a digital hand for me? Okay, can't see any digital hands raised, so we'll go to the action points arising, and they are on, just bear with me when I get there, they're on page 15 of 212. And the first was about agency reduction. And Lucy, you were going to ensure that the nurse agency reduction programme report contains the trajectory for reducing the number of healthcare support worker vacancies. And that's now presented in Katie's report. So thank you for that. And then we had a question from a member of the public, and Alan was going to provide an update to the outcome of the meeting held with a member of the public around that. That's still to be arranged, that meeting, Alan, isn't it?
No, the meeting's arranged. I'm seeing him on Monday. Okay,
super. Can you keep us brief to the next meeting on that then? That would be super. Thank you. Are there any matters arising the colleagues feel I've missed? Okay, so Glenn, it's a very busy time for the NHS, a new government, new Secretary of State. We know you're doing a lot of work behind the scenes to try and help the challenges which we're all facing. So over to you for your report, please, Glenn.
Thank you, Chairman. Yeah, our 34th Secretary of State for Health in the history of the NHS. I feel like I've had more of them than that in my time, but there you go. A number of things just at the start of the report, looking at some of the implications of having a new government. And one of the first things that's happened is this investigation into the performance of the NHS undertaken by Lord Darzi. Actually had the second of those two meetings, which is the final meeting earlier this week, actually. So the expert reference group met at the Royal College of Physicians on Tuesday and heard some of the emerging findings from that, and the report will now be produced and should be published by the end of this month, in time for party conference season and hopefully also in time for October budget. But very much what this report does is looks at some of the performance issues of the NHS and provides a bit of a diagnosis of problem. The next important phase in solving that is the treatment plan, which will come from this NHS 10-year plan, which is scheduled to be finished in spring of next year, which actually also will time in with a multi-year public spending review as well. So we have to wait to see what components make their way into that plan, and when that report is published, I'll probably talk a little bit more about some of the elements within it. One of the other things that the new government has pledged, though, is that we will return to the NHS constitutional standards within the life of this Parliament. So in the next section of our report, I remind us about those constitutional standards, which have not been met across the NHS for a number of years now. The urgent and emergency care 4-hour 95% standard is probably one of the most challenging in terms of being able to quickly get back to delivering that standard. And I set out some of the issues in the report. We are expecting to receive a winter letter. We always get a letter around this time of year that sets out some of the priorities for the coming winter. That's not been received yet, although we do expect there to be as well as an intention to deliver the 78% pledge against the 4-hour standard that was in this year's planning guidance. There'll be more of a focus on how we manage this winter safely, bearing in mind we are not at that 95% standard yet. So anyone who's watching this, a member of the public who maybe saw Channel 4 Dispatches report recently on Shrewsbury and Telford Trust will know some of the challenges that organisations can face when under pressure due to extreme urgent and emergency care demand. So we need to make sure that we respond to those, and we will be sharing best practice across group, as we always do, on how we manage that safely and how we improve flow. Also, I'm expecting a little bit of a return to payment by results, which I think would be helpful for us, because certainly the demand that we are now facing is higher than the capacity we've funded for. So we do expect that to hopefully result in at least a conversation about how we address that demand with better solutions. I then refer to the elective referral to treatment times. We are expecting to see an updated elective recovery plan any day now. I think it shows the evidence that payment by results has returned into elective specialties, and that's helped. And certainly as part of our financial plan this year, doing more elective work, taking patients off the waiting list, is a way of helping us financially, as well as obviously improving care to patients. And then finally, I'll refer to the Cancer Access 62-day standard. We've also, since the Constitution was written, we've also had the 28-day faster diagnostic standard, which I think for both of those cancer standards, there's pretty much a here and now expectation that we should be delivering those constitutional standards, and we'll no doubt reflect on that when we look at our performance later on in the meeting. I then make reference to the introduction of Financial Recovery Board. This is a really challenging year across the NHS, and we're in a challenging position. So we've agreed as a board to put what hopefully is a relatively short-term solution in place to give more focus and grip on the issue. And I refer to the arrangements there. We've had a couple of meetings now of the Financial Recovery Board. We've got a similar arrangement in our partner trust in Worcestershire Acute, which has been helping them also. So we will report on performance as we progress that. There's then an update from the medical division, very much in the forefront of some of that increased urgent emergency care demand. And it's lovely to see some of the things that they've been doing to respond to that, which have improved safety as well as flow and our performance. And our performance has improved compared to last year, as you can see within the report. We've had to, though, respond to the CQC issues that were raised in December, and that's led to us putting more staff actually into a number of parts of that pathway, which has not helped our financial position. And I hope that through that kind of long-term plan solution, we start to see some more solutions maybe outside of hospital, including social care improvements. It's also good to see the stroke performance. Frailty has been fantastic. So if you went back a few years, obviously we didn't have the frailty block that we built on site. We've been able to, with that great facility, build a stronger frailty team. So 6th consultant appointment is great to see. And I suggested to Jane that we may want to have just a look at the impact of some of these changes on length of stay and outcomes for patients, because I'm sure we can demonstrate that that's been a really positive addition to the capacity of the hospital. I won't go through all the other things other than to just point to those great words about the individual and team winners for the GEM Awards for this last quarter. So happy to take any questions, Chair.
Thank you, Glenn. An awful lot going on and much to be proud of, but still challenges for us. Questions or perspectives to Glenn, please. Glenn, what's worrying you most about the financial challenges we face?
Well, I suppose one of my worries about the bigger NHS financial challenge is that, together with some of the announcements on pay awards, that if there isn't any additional funding, we may have to stop doing some of the things that we wanted to do as an NHS. One of those actually being the funding of the elective recovery fund, because, as I've already said, that's an important part of our financial recovery, but more importantly, we're reducing the long waits for patients, and I just worry that that could be a victim of a further financial squeeze. So that's one we need to keep a really close eye on. And I think otherwise for us, I think it would be about making sure that our response to the challenge is more about how we get things right first time, how we improve flow, rather than necessarily having to cut things. So having an improvement approach to it rather than a financial squeeze approach to it would be the best way forward.
Well said, Glenn. Thank you. Any other questions to Glenn? Otherwise, we'll move to Jane on the integrated performance report. Jane, what would you care to pull out?
I can lead straight on from Glenn. Actually, it's almost as if we'd talked about it in advance, and we haven't. we're nearly in the second half of the year, and it is those two big concerns: urgent care and flow, and finance, and they're linked. So on the urgent care side, we've had congestion of ED, congestion and boarding going on right over the summer at a level that we really didn't expect. And so first of all, it's understanding the diagnosis. So why has that happened? And I expected to see that our length of stay had gone up, but it hadn't. That's quite interesting, actually, because when we look at it down by age, actually our length of stay, Glenn's point then around the great work that's been done in frailty, our length of stay for our older patients is actually a little lower than it was a couple of years ago, but overall length of stay is exactly the same as it was. And then the other part of that is urgent care demand. So we are admitting 12 extra patients a day than we were 2 years ago. 7 of those are being managed through those same day emergency care pathways, so they're not impacting on our bed base, but it's still lots of extra demand. But 5 a day are being admitted, and broadly there's an average length of stay of about 7 days. So our 35 patients, which are either boarding on wards or awaiting an ED in the morning, that's broadly the diagnosis of the problem. So the approach then is about how do we improve that, and that's on 2 things really. One is around admission avoidance. What can we do around the community to keep more of those patients at home? And then second is around length of stay reduction, because whilst it hasn't got worse, it could be better. So 3 real things that we're doing around that. One is around that investment in community services. So there has been some additional investment in community services, in virtual ward. We've got some new technology coming into OPAT, which is delivering antibiotics to patients at home. So some technology, which means a machine does the delivery of the antibiotics all day, rather than a nurse having to go in 4 times a day and deliver it. So that really increases capacity. And our urgent care response team increasing as well. And one of the things we're putting in the next few weeks is a specific response to our frailty SDEC, so that we can provide care at home if the patient can go home immediately. So a lot happening in terms of investment in community services. And then the other part is around the integration of community services. So that's particularly with our GP partners. So that urgent care, we've got our teams moving together and to be co-located in October. So the GPs who work in that out of care work and our community staff will be co-located. So there will be just some improvements available just by that co-location and integration. And the other is around the integration of the neighbourhood teams. And so that's really looking after the prevention side, making sure we've got proactive care plans in place for patients so that they're getting ill less frequently and requiring an urgent admission. And also a big piece of work that we need to do around nursing homes. We've done some of this before. Our nursing home admissions have risen. That's part of that 5 a day is from care homes. So revisiting all of that. And then the third thing is around that discharge to assess pathways, better care fund. We've had a huge impact on pathway 1. That needs to be replicated in pathway 2 and 3. So quite a lot of work going on that. So that's really the approach to improvement. So how can we improve the urgent care position, which is very much related to the financial position, as Glenn mentioned. So if we look at the case we're looking at later on around our investment in nursing in ED, some of that is to manage the congestion. So patients who are waiting in ED who should be on a ward, we're having to care for them in ED. So we're reducing the temporary workforce and putting in a substantive workforce. But if that flow was better, we wouldn't need those staff at all. So that's also part of our financial improvement. The other parts of that financial improvement are income. Now we've got the elective surgical hub, it's working. We can do more in terms of productivity across all of our elective pathways. So driving income and reducing the cost of delivery per patient that we treat is very much part of that financial recovery plan. And then lastly, it's around that real grip of our managerial and clinical teams at divisional level, at specialty level, making sure they've got those good cost improvement plans and they're delivering them. So those are probably the three main areas that we're looking at in terms of financial recovery. So after all that bad news, I wanted to end on some good. So firstly, we've got some really encouraging signs around August and the amount we've spent on temporary doctors and temporary nurses. So those things are coming through and they'll be in our next report. Really good to reflect on mortality reduction, which I'm sure Chizo will touch on later. And then lastly, the cancer waiting times are holding up well and they benchmark well. So nice to end on some things that we're doing well.
Great summary, Jane, and thank you and colleagues, hard work. Executive colleagues, I'm not sure we're going to talk about after Jane's such a comprehensive overview. Any questions to Jane? Otherwise, we'll dive into the detail. Okay, so I think first of all, over to you, Lucy, and then Chizo on quality and safety. Over to you.
Thank you, Chair. So a brief report from me today, just giving the heads up to a couple of things that will come here in the future. So we had a critical care peer review last month, and you see the highlights of the immediate findings and things that we needed to respond to, and Jane's already alluded to that investment that we've made in 24/7 critical care outreach as part of that. We have just received the full report, so that will come back through to Quality Committee at the end of this month and a summary back to board next month. Members will know that the national inpatient survey results were published nationally last week, and we're certainly not where we want to be. We haven't made the improvements that we would have liked to. We've made limited progress. So again, there'll be a deeper dive into that at Quality Committee at the end of September. One element of the inpatient survey that we knew had deteriorated significantly this year and has always been poor in the survey is around our food provision to our patients in our care, particularly the food itself, the food we offer, and the service and how it's delivered. So given that we knew that that was coming up in the inpatient survey, we held a summit. So clinical colleagues and Sodexo colleagues met together last month to agree how we're going to work better together to improve both the service delivery and the food offer. It was really good engagement in the room. We're going to set up a short task and finish group to focus on that. And we do know that Sodexo are already working in the background on revised and new menus, which are due to be introduced shortly. And then finally, from me, I just wanted to touch on the quality improvement work that we're doing around falls reduction, but in particular in relation to the use of bed rails. We do know that if bed rails are used inappropriately, they can cause more harm than not having a bed rail there to protect somebody from falling. So lots of quality improvement work going on in that space. And just what's summarised in the report is that the audit results, which actually show that our falls risk assessments, our bed rails assessments, and actually the positioning of them overall, the audit results are relatively positive. But there are a small number of occasions when we don't get it right. And that's where we're focusing our efforts, because it's when we don't get it right that patients could be at risk of coming to significant harm. So we're trialling a brand new way of approaching the use of bed rails. I'm not going to say much more about that today, but I'm hoping that I'll be able to report some positive outputs from that quality improvement initiative that we're currently piloting in our community hospitals. And I'll hand over to Chizo for the mortality.
Just before, Chizo, you come in on mortality, just for members of the public, in case you're unaware, and we apologise on the issue of the quality of the food. Wye Valley has a PFI arrangement whereby things like the food and the cleaning are provided by a third-party private company called Sodexo. Like all of the PFIs, they're extremely expensive. We pay over £29 million a year as an NHS at Wye Valley for Sodexo to provide those services. And whilst we always try and ensure that members of the public get the level of service they would hope for, we are having to work through Sodexo to achieve that. So we do apologise to patients and their families if they're not happy with the food, but as Lucy said, we're doing our best to get them to change the menu. Chizu, on mortality, anything you'd like to emphasise?
Yes, thank you. So our latest mortality indices, so covering April 2023 to March 2024, is really good. It's dropped to 98, so well below 100. And this is associated with, when you look at our crude mortality rates, is 1.04% from a previous high of about 5% a couple of years ago. So significant improvement in those as well. And is associated with improvements in mortality outlier groups. So things like COPD, pneumonia, heart failure, these are conditions where previously we had struggled. However, the diagnostic group that we still need to work on is fracture neck or femur. It has been an outlier, and we have had a mortality outlier alert, which we were aware of. And our initial review shows that the area that we can make improvements on is improving the timeliness of getting the patients from ED to the ward, because we know that the longer they stay on in an emergency department, the worse their outcome. So we are taking a quality improvement approach to implement a faster pathway for these patients. So we will do the usual PDSAs and try and embed some of that improvement. So I'm hoping to be able to report on the outcomes of the QI.
Thank you very much, Chizu. Any questions, colleagues, to Lucy or Chizu? Okay, thank you for your hard work. And Andy, how is the operational engine of Wye Valley going? Over to you on activity.
Thank you, Russell. Jane's already covered a lot of what I was going to say around the urgent care pathway, which are, Jane's alluded to, remains under pressure, and our ED attendances remain above the levels we saw in the winter just gone in 23-24, and we work on our plans for this winter, along with consistent levels of ambulance conveyances, which remain the same as last winter. One of the plans that is being worked on nationally and regionally is how do we improve our ambulance handover. We know it's one of the highest risks in the NHS is holding ambulances outside of A&E and them not to be able to respond to the community. And at Wye Valley, we pride ourselves in trying to reduce those ambulance delays to an absolute minimum, but we know, particularly comparing across the group, that we can do more and we can do better. So one of the initiatives that's being rolled out nationally and regionally is adopting some of the improvements that have been seen across London, where they've taken a zero tolerance over any ambulance handover delays over 45 minutes. So that's being rolled out regionally. As for Hereford and Worcestershire, we are looking to implement that in October, and that requires three things. It requires an ambulance culture change, it requires an acute hospital culture change, and it requires strong clinical and operational leadership across the urgent care system to achieve that. But we've got a workshop across the ICS this month to work through the detail of that. Some of the work we have done in Herefordshire and in Wye Valley is our community response hub, which has continued to see an increased number of referrals from colleagues at West Midlands Ambulance Service into that community hub. And last month we saw almost 250 referrals go into that community response hub, and that's up 100 from June. So 150 in June, 250 in July. One of the concerns there is only 8 of those referrals came from crews on the scene. So that call before convey from paramedics on the scene with patients is really low. So we know we need to work with YMAS colleagues around how we improve that call before convey to enable us to improve that 45-minute handover. But also we undertook a missed opportunities audit with NHS England in recent months to look at our ambulance conveyances, and we do know that roughly 2 out of every 6 ambulances could also be dealt with in the community. So as well as improving our own internal processes, we need to work with Wye Valley, with West Midlands Ambulance Service around how they're accessing our community service and how they are capitalising on our revigorated community response hub and SPA development that will kick off in this month and into October. Also highlighted in my report, Jane alluded to, in terms of the improvements we have seen in pathway 1 for Herefordshire discharges and discharge to assess. And although there's more work to do there, we are seeing a definite improvement in the number of Herefordshire delays across our pathway 1 to 3 discharges, but also the responsiveness when there is issues and spikes in increased delays from colleagues across the system. Our basic concern still remains with Powys. Powys delays now make up, or have done the last couple of weeks, a bigger proportion of our delays than Herefordshire. And we're working very closely with Powys colleagues to try and get ourselves in a better position for those Powys delays as we head into the winter. But not just delays in terms of admitted discharge delays, also they're offering for same day emergency discharges into the community is also needs further work ahead of the winter, so we can discharge more patients from our same day emergency facilities back into Powys. And then, as James already alluded to, our elective surgical hub opened on the 8th of July, 2 new theatres and a cataract suite. So our Vanguard theatre has left site, and also over the summer period, with the go live of those 3 new theatres, we're able to undertake some essential theatre maintenance over the summer, which has ended this week. But from next week onwards, we're all guns blazing with 10 theatres operational to enable to improve our elective throughput and reduce our waiting list. Taking the comparison of the first 8 weeks of the go live of our elective surgical hub and looking at the same 8 weeks last summer, we've delivered over 350 more patients through our theatres, and that was with just 1 additional theatre, because we had 1 out for maintenance and 1 was replacing the Vanguard theatre. So really promising levels of activity, but we know there's lots more to do, Chair, going into the second half of the year, and we're undertaking those reviews with our divisions at the moment to ensure that their plans are robust and we're maximising the productivity gains of those new theatres. Thank you.
No, thank you, Andy. Lots of opportunity for us to go after. Questions or perspectives to Andy? Okay, Andy. And obviously we've got the ED decant coming up next week. Just for a second, brief members of the public on that in case they aren't aware.
Yeah, absolutely. Thank you, Russell, for mentioning that. Yeah, we have a decant of our ED for 3 weeks starting tomorrow for 23 days. That's to allow essential maintenance work across our ED department, including replacing the flooring and ventilation that is much needed. We've got really comprehensive plans with clinical operational teams and oversight over the next 3 weeks. It is absolutely business as usual for members of the public, but I would urge members of the public to choose well and choose wisely before attending ED, but it is business as usual, Chair.
Thank you, Andy. We'll move on then to Jeffrey and workforce. Jeffrey, on the people side, what would you care to put out?
Oh, thanks, Russell. From the people side, we're still seeing high sickness absence across the NHS compared to 2019. And this is largely down to mental health conditions. So we will be participating in a national study, which will run for the next 6 to 12 months, which aims to explore the reasons for sickness absence and also what further interventions can be put in place to support staff and reduce sickness absence. So I'm looking forward to that. The study will be kicking off from early October. Following the recent government announcement about health checks, we will be a pilot site running health checks for staff over the next 6 months, and that ties in nicely with our ambition to look after our staff and support health and well-being at work. So that program will be kicking off as well by the end of September. In our efforts to contribute towards a more tolerant society, we are encouraging all our line managers to sign up to the NHS Inclusive Leadership Pledge so they can take actions to promote good relations and also ensure that compassionate leadership is spread across the organization in terms of how we handle situations. through our concerted efforts over the last few months, I'm pleased to say we're now seeing a positive shift in performance appraisals. And that is important because it supports staff productivity, it supports career development, and also supports staff retention. So I'm really pleased to see that we're now seeing that positive shift in performance appraisals. Those are the key things I wanted to pull out, Russell. Happy to take any questions.
Thank you, Jeffrey. Questions and perspectives to Jeffrey? What's worrying you most, Jeffrey?
I think it's the financial challenge and the productivity challenge that we all face with. So we working actively with our staff to try and ensure that we can be more productive and support the financial challenge faced by the organisation.
Yeah, no, I agree with that. Well said, Jeffrey. Okay, thank you. And that leads us and segues us nicely to Katie. Katie, how are you seeing things?
Thank you, Chair. And I won't rehearse some comments that colleagues have already made on the financial position, but just in terms of a couple of key headlines and highlights this month as usual. So year to date at the end of July, we've got an overall adverse variance of £3.2 million compared to where we'd planned to be, which is primarily, as we've said, through under-delivery of our cost and productivity improvement, but also important to draw out partly driven by a change in the accounting treatment of our PFI arrangements, which has had a year-to-date impact of £700,000 reflected in this month. So it's two aspects to our overall adverse variance to date. In terms of just linking to Andy's point around strong elective performance and the opening of the elective surgical hub, that's supported a £700,000 positive position on our elective recovery fund income. So we are seeing that play through in our income recovery. From a forecast perspective at this point, we're maintaining the forecast on plan, but clearly acknowledging that there are known risks to that position and some of the mitigations that we've already explored. So that continues to be something we're watching closely, but just so we're clear on what we're currently reporting in terms of the overall likely exit. From a capital perspective, we've invested £5.2 million year to date. We've got a significant programme, but large elements of that were to deliver slightly later in the year, and overall the programme remains quite constrained, but we're working to start to allow some of those absolute replacements to start to take place. From a cash perspective, just to update board, so we thought we would need cash support in Q2, but as a result of some close cash management through the team, we're not requiring support in Q2, but we are anticipating that to be required in Q3, so we're liaising with NHS England accordingly. And just to remind colleagues, cash support is available in line with our deficit plan, but in the event that the requirement for cash is driven by us being off plan, that will become increasingly difficult to access, so it remains a significant risk for us. Thank you, Chair.
Very clear. Thank you, Katie. Any questions or perspectives to Katie? Katie, if there were three things we needed to do to achieve a Q4 run rate which we thought were acceptable, what would your three things be?
So productivity, improving theatre productivity and utilisation of that capacity so we can drive at ERF, and the same on sort of the outpatient side, and the urgent care flow improvements that Jane has touched on, which will allow us to deconvest and reduce spend there, and our reliance on temporary workforce. Okay,
great, thank you. Super summary. Thank you, Katie. Okay, team, shall we move on then to the item for approval, which is the Emergency Department Workforce Investment Business Case, relates to some of the comments made earlier, as well as the quite extraordinary increases in demand all emergency departments have seen, but us in particular. Just before we get into this business case, I do want to thank all of our emergency department frontline teams. They work incredibly hard under incredibly stressful circumstances, and I would want them to know that it is greatly appreciated by the board. So Lucy, what are you asking for? And then we can make a decision.
Thank you, Chair. And as you say, some useful context leading up to presenting this case. Just so board are aware, Trust Management Board considered this case 2 weeks ago and recommended it for presentation to board today. And the case has been through a non-executive director pre-board discussion also. Essentially, the case is seeking investment in nursing staffing, and Katie will cover any financial aspects after me. The case, as you can see, presents three options. Option one is to reduce our staffing levels back to the baseline budget and establishment that was set pre-COVID. Option two would be to adopt the full range of the Royal College of Emergency Medicine workforce standards, which are guidance rather than standards, and would be deemed, if you implemented all of them, as gold standard. And option three, which is the preferred option and what we're seeking approval for today, is based on several factors. So external visits and inspections and some benchmarking that we've undertaken across our foundation group. Now, given the CQC inspection in December 2023, where they ranked us as inadequate for safety, some of that was driven by staffing in particular, and therefore additional staffing was put into the department in December to address those safety concerns, and are clearly beyond the baseline budget and are driving some of the cost pressures that we're currently seeing. As I say, the preferred option is based on the staffing requirements as we see needing them today for a department that's under operational pressure, that's experiencing congestion, with long waits for patients either waiting for a bed or to be assessed for care. The case addresses the safety critical posts that are deemed for the department as it is today, so includes posts associated with oversight of the corridor and the waiting room. Clearly, the case isn't normalising corridor care, but recognises the operational pressures that the department currently faces. When we undertook our benchmarking, we found that we were an outlier in comparison to the foundation group, and therefore proposed that we should provide 24/7 Band 7 senior clinical leadership cover to the department, increase the management in that senior workforce, and increase our education support for the team. And given the test of change and the positive benefits of that, the case seeks to retain the nurse navigator as part of the investment. What the case doesn't do, but work is ongoing to address this, is to review our shift patterns to see if we can better match our workforce to the peaks in demand that we often see mid-afternoon into the later evening. And so the team are currently reviewing whether we should have staggered shift times rather than the two-shift system that we currently offer. And that review of shift patterns is due to conclude at the end of September. Despite the high number of vacancies in the department, the recruitment trajectory for the end of the year is really positive. And we are projecting that by the end of December, we would be fully recruited to the original budgeted establishment position. But given our strong recruitment now, we are predicting that by April 2025, if option 3 is approved, we should have recruited to all of those posts by April 2025. And then finally from me, before I hand over to Katie, is people have already alluded to it, but if our emergency and urgent care work streams start to be implemented and come to fruition, then there would be an opportunity to reduce the staffing requirements within the emergency department, because we would no longer need to provide a corridor nurse, for example, or the level of workforce that we're providing to the waiting room to keep patients safe currently. So there would be an opportunity in the future to review the staffing model and reduce the level of investment required at this point in time. Thank you. You're on mute, Russell.
So we want to appropriately staff in a sensible, pragmatic way the ED department to cope with the level of demand we're seeing and the challenges we're facing. Katie, how much will it cost us?
Yeah, thank you, Chair. So the increase in the workforce of 10.76 full-time equivalent will cost £491 £5,000 a year. That's over and above what we're currently budgeted for, but is clearly in line with what we're spending today anyway. And of course, we're spending it in a really unplanned and expensive way through bank and agency usage. So the case sets a target of a reduction of bank and agency of 831,000, so that this would make a positive contribution in run rate terms. That is only a proportion of the total bank and agency spend currently incurred in the department, partly because there will always be some level of bank and agency in terms of managing short notice sickness, for example, but partly also to ensure we don't double count with the existing nurse agency reduction target, which will apply to this department as for any other.
Okay. But it's a sensible proposal. Do you agree, Katie?
I do.
Thank you. Questions and perspectives, Glenn?
So I am supportive of this, and as Katie's outlined, the recruitment, the positive recruitment situation that we're in, hopefully could lead to this being a reduction in expenditure run rate. I think my concern, which Lucy touched on there, was that we're funding a queue as opposed to solving a queue, but that's the reality of where we are today, and obviously responding to the CQC issues. But we shouldn't lose sight of trying to put some other solutions in that treat patients in a different setting. And I suppose my question for Lucy is just to make sure, come that glorious day when we're able to do that, would we be able to redeploy these staff into other roles?
Absolutely. So all of our nurses are recruited to the trust and are informed at the point that they join us that they may well, if we ever find ourselves overstaffed, that they may well be redeployed into alternative roles, which would be available for them, yes.
Apologies. Francis?
Thanks, very much the point I wanted to make, Glenn. This is a pragmatic sticking plaster to a situation that we don't want to continue. So pleased to see in the proposal that there is going to be a rigorous continual assessment of how that's working, so that we don't just turn this into this is the way we do things. It's a bit like borders. It is a pragmatic solution, and it's the worst of the things that, the best of the poor options that we can do now, but we don't want to normalise it. We ought to be able to right size our emergency department by having primary and secondary prevention and more investment in general practice and other community services.
Agreed. Thank you. Ian?
Yeah, happy to support the proposal. I note that actually what we're doing is we are creating a team to replace and reduce cost on agency and bank staff at the moment. Of course, we already have targets to meet around reducing agency and bank staff as part of our financial plan for this year. I just want to be clear that we're not double counting, that the savings here are not being double counted against savings we were anticipating anyway.
I think Katie sort of noted that slight risk, but she was confident that we weren't. Katie, is that correct?
Yes, so we're currently spending on average £2.5 million a year on temporary workforce in ED. In this case, assumes an 800k benefit. So the maths isn't perfect, Ian, but I'm confident broadly we're not double counting.
Thank you, Katie.
That's great, thanks.
And Nicola?
Yeah, I know I've raised this before. Sharon, Kieran and I met with Lucy and the team on Monday, and we kicked the tyres on this for about an hour, trying to get into the detail. And I just want to check with Alan Dawson that it's right to put a summary, not a verbatim, but maybe the questions that we asked, and we were well satisfied with the answers we were getting. But I think even before it gets here, for the non-execs that weren't at that meeting and the execs, it's just good to have a headline of what we have asked already, as it will look like we haven't challenged to the extent we have. So
no, excellent point, Nicola, excellent point. Alan, can we just make sure that happens?
It is, it's in the covering paper.
Oh, right, I haven't seen it, apologies.
And, finally, Kieran, and we'll move on as we've all discussed this.
Happy to support the business case, but I do note it's one of a number of areas where we're having to increase our cost base because we need to meet service needs. The question I've got is, to what extent do we involve our commissioners in these business cases, and what is their response?
Glenn, your view on that? Thank you.
Yeah, thanks, Kieran. It goes back a little bit to the point I made earlier about the need for there to be at least a kind of annual reconciliation of demand and cost within urgent emergency care. At the moment, UEC costs are covered in a block contract, so we're not paid if demand goes up. But I'm expecting to see something in this year's planning guidance which resets that at least on an annual basis, and that would, for us, based on our numbers, lead to a conversation with commissioners about the affordability of the demand that we're seeing as an organisation.
Yeah, I mean, the big opportunity for everyone is to increase the ability to provide care at home, improve prevention so that people don't end up in an expensive A&E. Every single A&E visit, members of the public may not be aware, costs around £200, the average. It's £200 every time you come to an A&E. So if you come to an A&E and it's for something that could be treated in a pharmacy, you can save the system £150 plus just by going to the pharmacy if it could have been dealt with at an A&E. So A&Es are an extremely expensive place to provide care which can be provided elsewhere. So I think, as Andy mentioned in the integrated performance report when talking about the decant of the A&E, I would plead with members of the public. The A&E is there when you have an accident of a substantial nature or an emergency. Otherwise, please do try and use other parts of the healthcare system which are there to help. Okay, team. As we heard, a number of colleagues have been through this. We've all seen the report. We've asked our questions. Now, if you're not happy to approve this business case, could you please raise a digital hand? Duly approved. Keep us briefed, Katie and Lucy. Thank you for your hard work. We'll move on then to some items for noting and information. The first is the ICS and One Herefordshire update. Jane, over to you.
I've covered most of this already, actually, in my opening remarks, which relate back again to what we've just been talking about in terms of integration, expansion of community services, those being the answers to congested urgent care. So really the report is just highlights the work that's been going on, but also notes that the process to reprocure GP out of hours has started. It's not. It's still in the very much the planning stages, but that is very much important to us in Herefordshire because of the level of integration that A, we've already got, but B, we're planning as we co-locate these services in September and October.
Thank you very much, Jane. Any questions or perspectives to Jane? Okay, so we'll move on to the Trust Infection Prevention Annual Report. Lucy?
Thank you, Chair. I'm going to be really brief here. The annual report has been through Quality Committee, who were happy with the content, and Quality Committee do due scrutiny on a quarterly basis on infection prevention matters and performance indicators. But if I was just to summarise the year very briefly, high levels of respiratory infection, a large number of outbreaks, but to note, all those outbreaks were managed well, and where possible we were able to keep clinical areas open to admissions and discharges to prevent further congestion within our bed base. We were disappointed to report one MRSA bacteremia. Lessons were learned around that in relation to full screening protocol and decolonisation. However, for those other externally reportable infections, in all but one, our performance last year was an improvement based on the previous year, which is really positive, with the exception of E. coli bacteremias, and we've got some quality improvement that focuses on catheter-related care that we anticipate will see a reduction in E. coli bacteremias moving forward. And then finally from me, we do remain on intensive support from NHS England. We went into intensive support over 2 years ago now in relation to our C. diff outlier status. They have overseen our improvement activities over the last 12 months, and they're pleased with the progress that we're making, and we'll continue to do due scrutiny at Quality Committee on a quarterly basis moving forward, Chair. Happy to take questions.
Thank you, Lucy. Any questions or perspectives to Lucy on this report? Lucy, I'm going to ask a very strange question, but I've asked it elsewhere. I don't expect you to know the answer, but if you could find out for me. I have seen a study which talks about the importance of lowering a toilet seat when you go to the toilet before flushing, and the enormous benefit in terms of the spreading of germs. I go to a number of our toilets and I see they don't even have a toilet seat. Could you find out for me, if you don't know, whether any of our public facing or patient toilets have toilet seats? The second thing that members of the public may not be aware of, and Glenn may recall, a non-exec colleague of ours in another place had been to an infection prevention control conference. And somewhat as a joke, what they decided to do was to check how many people washed their hands, nurses and doctors, after having gone to the toilet. And they were horrified to find that 60% of the male doctors didn't wash their hands. So this is a plea to everyone who uses the toilet on our premises. Please do wash your hands, even for 5 seconds, if not 20. Use lots of soap. But there are real benefits to be had in terms of germ control from putting down a toilet seat and washing your hands having gone to the toilet. The old-fashioned things that our parents would tell us about are still as relevant in infection prevention control as well as the very modern stuff that I know, Lucy, you're on top of. I assume you don't know the answer to my question.
I don't, but I can find out, Chair.
Thank you. Okay, team, we'll move on then, having gone into a level of detail that some of us wouldn't have wanted to, into the perinatal safety report. Lucy, back with you.
It is back with me, thank you, Chair. So this is the quarterly perinatal safety report. Again, this has been scrutinised at Quality Committee, and the consensus there was that there was no requirement for us to escalate any matters in particular for board attention. However, there are several areas of focus in relation to quality improvements in the service. The first we did touch on last time we reported, which was around our postpartum hemorrhage and the work and audit that we're undertaking there to improve our response to postpartum hemorrhages. And then we've added 2 more recent quality improvement projects, following on from a cluster of incidents and reviews more recently, particularly focusing on reduced fetal movement. And there is currently a national publicity campaign out for expectant individuals, just to say, please do not rely on home Dopplers. If you're experiencing reduced fetal movement, you should contact your maternity department and seek help. We're also focusing on our preterm pathways, and in particular just ensuring that our referral process and criteria into the preterm pathway are right and proper. And we're also looking at the ongoing monitoring that people on the preterm pathway receive to check that that meets best practice guidance. We've got audit activity going on in those areas and can report back in future reports on those matters. And then the other element I would just want to pull out of the quarterly report is that the neonatal and maternity leadership team have participated in the first wave of the Perinatal Culture Club, which is part of the Maternity and Neonatal Quality Improvement Network. And in the pack is just our progress against 14 of the indicators from the original culture survey. So what that shows, and it's difficult to see in the pack and it's difficult to interpret, so I'll help to make it much easier for you. In 12 out of those 14 indicators, we have made positive progress since the last culture survey. In 2 out of the 14, there's been a slight deterioration, and that's in relation to workload and emotional well-being. So we are currently ensuring that we are publicising our wellbeing offer to colleagues working in those services so that we can improve our position on that matter. And then just of note, because we did scrutinise this at Quality Committee, there is a ranking percentage against those indicators that wasn't clear. I can clear that up for board now. That ranking was the ranking in comparison to the original culture survey when all trusts were ranked against one another. And actually it would have been helpful if we hadn't included it in this report, because actually there are only 10 trusts that have gone through the survey so far, so we won't know where we rank against all of the trusts in NHS England until they've all been through the programme. Happy to take any questions. I'll take the rest of the report as read. Thank you, Chair.
Thank you, Lucy. Any questions or perspectives to Lucy? Francis?
Thank you. And as Lucy said, lots of detail of this through the Quality Committee. But just in terms of how we compare with other people, one of the real strengths of the foundation group is our ability to work with colleagues across the group to compare and contrast and learn from each other. So really applauding that, firstly through the local maternity neonatal system with Worcestershire, but also the wider group and how we learn from each other. So keen that we continue to do that as much as possible.
Great, thank you, agreed. Any other questions or perspectives? Just a couple of things for me, Lucy, just to make sure I'm understanding the numbers correctly. So the way I read the numbers is in July, only 1/3 of our pregnant mums had a vaginal birth. Is that correct? Does that sound correct? 36.7%.
Yes, and we do know that our caesarean section rates are higher than perhaps the national benchmark. And we've had previous presentations through Quality Committee around the Robson groups that sit within, which are around whether you're a first-time mum or a mum who's had multiple births or a previous section. We are due to have the Robson's group audit presented to Quality Committee towards the end of this year, which would just help us understand better why we're an outlier and where we need to focus.
Sure. I guess it would just be interesting at some point, because I can't, I don't understand all of the terms on ours. But this is just a general population health issue. Elective C-sections are becoming more popular, but they're not without consequence for babies' health, just for expectant mums, particularly on gut flora. So I'm sure we do a lot of work there. We are quite extraordinary in terms of our percentage of mums who are smokers at booking. At 6.5%, that's a phenomenal number. That's almost half what it is in other bits of the foundation group. So whatever work we're doing in advance is really very, very commendable. But what is on the other side more worrying is that a quarter of our mums, and occasionally up to 1/3 of our mums, have a BMI above 30. And I would just again say, and far be it for me as a man to say, but the evidence is quite clear. High BMIs aren't great for babies or for mums as they're expectant. So any help we can provide whilst you're looking forward to the joyous birth of a loved child, in terms of getting the BMI down, please don't hesitate to reach out to us. But the smoking stats are phenomenal. Well done, team. Colleagues, happy to move on? Okay, we'll move on then to the foundation group minutes and action log from the 7th of August, which I will take as read. Any questions or perspectives on those? I just would encourage members of the public to either see the YouTube version of those board meetings, but they are different from these board meetings and that they do more comparative work, and some really interesting conversations come out as a result. The Integrated Care Executive Report. Francis?
Thank you very much. I'll take the paper as read, but just wanted to pick up about the particular progress around the Better Care Fund. We've talked earlier about how we try and divert patients to a more suitable care environment rather than ED or being admitted as emergency patients. We've talked previously at the board about the risk of hospital acquired functional decline. So one of the things that we're trying to do is to have a really fast response so that we can get people home or not admit them in the first place. The Better Care Fund is a joint pot of money that the ICB and the local authority commit together, and that is our opportunity to do things differently, as not all of that money is committed recurrently. So anything we can do to avoid one-off purchases of care packages for people gives us more flexibility to do the left shift as we're committed to doing so.
Thank you, Frances, and thank you for your hard work in this area. Any questions or perspectives to Frances? Frances, again, you may not know the answer to this, but it would be informative to help at least me to understand. Particularly our nursing homes in Herefordshire, are they really engaged when we reach out to them to provide that enhanced care in care homes?
Everything's always a curate's egg, but broadly, yes, there is a well-attended care home forum, and with colleagues from general practice and from the local authority, a really active group trying to be proactive and supporting them on some of the information sharing, digital care records, and what they need from the rest of the system to provide best care, and really focusing on that. There's a programme called Enhanced Health in Care Homes, and one of the metrics that we look at through the Integrated Care Executive is numbers of patients being admitted. So as Jane alluded earlier, some of those rise in admissions, we're looking at that by Prime Care Network. There are some frustrations about data sharing that I don't want to get to in here because it's not good for my blood pressure. But doing that through EMIS will be the way that I think we can try and change the course of history for some people with that.
Okay, thank you, Frances. Any other questions to Frances? So I think we're then on to the Quality Committee report and minutes from the 30th of May and the 27th of June. Ian, anything you'd like to add to these?
Nothing to add, Chair. There's a comprehensive set of minutes there which indicate the depth of consideration we give to many of the important issues that we've touched on today, and those are some of those are highlighted in the summary reports. Happy to take any questions.
No, thank you. And any questions or perspectives to Ian? What's worrying you most at the moment, Ian, on the subject of quality assurance?
I think it's the impact of the things that we've touched on, the pressures the hospital is under, patients boarded on trolleys, and the impact that has on quality and safety. And as the summary reports point out, we consider that at every meeting. And while the resolution of that is to improve the flow of patients through the hospital so that actually we have beds for all our patients, we're also keen to scrutinise the quality and safety risks that are attendant on having additional patients on each of our wards.
No, thank you, Ian. Okay, colleagues, any other business? Please raise a digital hand. Okay, in terms of questions from members of the public, I know we've had two from Chris. Chris, we miss seeing you digitally, if not physically. Lou, would you care to please read out Chris's two questions?
I will. Question one, there's concern nationally that the number of overseas nurses are on temporary visas, meaning that despite paying income tax and national insurance, they have no recourse to public funds such as child benefit, housing benefit and universal credit for at least 5 years. How many overseas nurses employed by Wye Valley NHS Trust have only temporary work visas, and how can the Trust Board do anything to support these nurses, for instance by lobbying the government to change this unfair rule?
Thank you, Lou. Is Jeffrey going to answer this for us?
Yes, Will Russell. Well, our international nurses are sponsored on the 3-year temporary highly skilled worker visa initially. After they've been in post for 5 years, we then support them to apply for indefinite leave to remain in the UK. We currently have 396 nurses on the temporary visas, and we will be supporting their applications for indefinite leave to remain in the UK in due course. So far, we've made 44 applications, and all those applications have been successful. So we haven't had any application rejected in terms of applying for indefinite leave to remain in the UK. We are aware of the national concerns about the restrictions on those on temporary visas, and we have raised this with NHS employers so they can then pick this up in their discussions with the government. Okay, thank you, Jeffrey. I mean, I think we're a small clog in a bigger wheel, but I would just like again to put on public record my now enormous thanks to those international nurses who come and work at Wye Valley at enormous personal and emotional sacrifices. They often leave loved ones and families in their home countries and come and work in the NHS. And it's often a need to work in a foreign language, English, and they persevere through that and go through all the educational hoops and challenges, as well as often living on their own. The sacrifices our international nurses make are immense, and we are incredibly grateful. Thank you. And Lou, Chris's second question.
When provided with equipment from Wye Valley NHS, such as crutches, commodes and other aids to assist patients at home, what information are patients provided with to let them know when and how to return these items? How much of this type of equipment lent to patients is not returned or is delayed in return? And what is the cost to Wye Valley and the NHS of such non or delayed returns?
Who's answering this one, team?
I can, Russell.
Thank you,
yeah, thank you, and thanks, Chris, for the question. I mean, the current process for patients returning equipment, such as crutches and frames, etc., is they should be asked to return them. They're also labelled with a sticker placed on those mobility aids, but it does rely on the patients returning them. And over the years, we have had amnesties asking for patients to return them in drop-off bins for any equipment. But it's really clear from Chris's question and Chris's experience that this isn't as robust as it could be. We do know that for larger pieces of equipment, i.e. ordering loan beds, that's done through the council contract. There is a system whereby the monitoring arrangement of equipment to be collected, and that is in place. I think it does raise a point around how much does it cost us. I know we're not unique as an organisation. I think it's really clear that and great that Chris has raised this question in terms of reflecting that patient experience and learning for us, as well as ensuring that we can improve our services and deliver value for money. So we've added it as part of our financial recovery board and as part of our SIP schemes in our integrated care division to take it away to look at how we can cost that opportunity and make our processes more robust. So I thank Chris to bring that to our attention.
This is a long-term problem that the NHS has suffered, and if I know it's something like a colostomy bag or catheter that has been unused and patients try and return them, they're no longer able to be used within the NHS. So getting it right first time is critical in this regard. Okay, team, members of the public, lovely to see you. I look forward to seeing you at our next board meeting. Well, I will actually be on holiday, so Francis will be chairing it on my behalf. And in the meantime, everyone, please take care. Can I suggest to board colleagues we have a 15-minute break and we get back together again at 2:30. See you then. Take care.